Welcome to the Jerry Powell Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome back Lona Mody, who is a geriatrician, translational infectious disease researcher, and professor at the University of Michigan and the Ann Arbor VA. Lona, welcome back to Jerry Powell.
It's great to be here. Thank you.
And we're delighted to welcome Peter Chin Hong, who is an infectious disease physician and medical educator, professor at UCSF, and associate dean for regional campuses. Peter, welcome to the Jerry Powell Podcast.
A pleasure to be on, Alex and Eric.
Alex, we haven't had a COVID podcast in a long time. Is that right?
It's been a minute.
It's been a minute. So today we're going to be talking about COVID updates. And I'm super excited. We got a lot to cover, from thinking about COVID boosters, where we are with that, potential treatments. But before we do, we always start off with a song request. Who has a song request? Is it you, Peter?
I do have a song request. I want to hear Kelly Clarkson, and I want to hear her sing, well, not Kelly herself, but Catch My Breath. And the reason why I'm choosing it is because it's respiratory virus season, and we don't want our patients to catch their breaths.
I love this because Peter gave such a great list of potential songs.
So many good ones.
Yeah, I was voting for cough syrup. That was a great one.
That one would have been quite the challenge. This one's a little bit more straightforward.
I think cough syrup, though, I'm not sure. I think it may have been the way the kids take cough syrup. Not really.
Yeah, I think that was the meaning too. I got that as well. Waiting for the cough syrup to wear off.
Yeah.
Little bit different from the way that we mean it.
So wise choice on this.
Wise choice. Here's a little bit. I don't want to be left behind. Distance was a friend of mine. Catching breath in a web of flies. I've spent most of my life riding waves, playing acrobat. Shadowboxing the other half, learning how to react. I've spent most of my time catching my breath, letting it go, turning my cheek for the sake of the show. Now that you know this is my life, I won't be told what's supposed to be right. Catch my breath, no one can hold me back, I ain't got time for that. Catch my breath, don't let them get me down, it's all so simple now.
That was great.
Bravo.
Awesome. That was fantastic.
I did hear her once at Central Park when I lived in New York. She was like playing, and I did not go in to pay for it. I just listened outside. That was my only Kelly Clarkson
an amazing
experience.
Singer. I remember that early American Idol. So good. I had to take that down about 2 octaves to sing it. Thank you, Peter.
All right.
You're welcome.
Lona, I am not sure you remember this, but over 4 years ago, mid-March of 2020, we did a podcast on a novel respiratory virus that was coming out of Wuhan. And we asked questions like, what should we be calling this? COVID, SARS-CoV-2? And man, things have changed since that first time that we had you on to talk about COVID over the last 4 years, huh?
Yes, it has been 4 years, over 4 years, and it seems like so much has happened. We all have grown so much. The virus has changed so much. The world has changed so much. So yeah, it's a good reflection. We know so much now than before.
Yeah. And I mean, I'm just reflecting because it feels like back in early 2020, it was almost like we were dealing with another virus. Like Alex and I did some virtual palliative care in New York when the first kind of wave hit New York, and holy smokes, the people that we were seeing were so sick. And then when it came to San Francisco, again, that first year, diffuse lung injuries that we're seeing, everything else, it was devastating. And 4 years later, it almost feels like we're dealing with a different virus. And I know that's probably a stupid statement of me. I probably get a lot of feedback on that statement, but I'd love to hear kind of how you think both of you, how you think, like where are we with COVID right now? Just from a virus perspective, not treatments or vaccines yet. Peter, does it feel different to you?
It feels different, but it also feels the same. The way it feels different is that your neighbor, your cousin, the person at work isn't getting as sick in terms of being debilitated anymore or not being as fearful. But it feels the same in that, I was on call a lot over the summer and I took care of a lot of people behind those hospital walls. And, some people are still getting very sick. It's not the same universal age groups anymore, but there's a select group, kind of like influenza almost. And when you look at the numbers, actually last year in 2023, even though we're in a recovery phase, there were more than 75,000 deaths. So I think that dissonance or that disconnect is a little bit, disconcerting to me.
Yeah. Why do you think there is such disconnect?
I think there is because the virus has evolved certainly. Yeah. And the virus always evolves with the variants, but we've evolved even more in terms of getting more immune as a population. So there's a big force field in society. So that's changed. And we don't see hospitals being strained as much anymore. You don't see body bags, not the same sort of heightened impact on society. But you are seeing some people who are still ill. And I think that disconnect is why people don't often think of themselves being at risk in the same way, which is more variable in 2024 than in previous years.
How are you thinking about it, Lona?
Yeah, I think I remember in the early few months, the amount of stress that I personally experienced because all of my research has been in older adults nursing home population. And the deaths that nursing homes experienced was simply devastating. There were stories about multiple people on the same ward, same unit, all of a sudden having COVID-19 and unfortunately not making it. The impact on staff, the impact on families, I think that probably deeply impacted me more than I thought it would, considering that there were no early answers. So that was one thing, that early phase that I personally went through along with several people in that industry. I remember the happiest day was certainly when the vaccine news came out, and I probably jumped several times in my office that finally we have some good news that's going to make a difference. I was really happy that day. And then, of course, other treatments and other sort of medications and such came out. We saw the worst and the best of humanity in those times in terms of call schedules, people stepping up, or people worried and stressed out. So that was a big portion of the first couple of years of COVID in my life personally. But after that, I think people have become used to the virus. I had heard several virologists mention the same thing as Peter was mentioning, that now the immunity is over 90% of the US population is immune, has some sort of antibodies to the virus. And that's probably the reason that people feel the need to move forward and not be held back anymore with the worries that are related to the virus. So I think that's how I'm thinking about it right now. Clearly, scientifically speaking, we need to learn much more than what we know right now about the virus, about the transmission, about the treatment, and about the long-term sort of implications of a global world that we are in.
Yeah. I also wonder around that disconnect, how much of it is like we all kind of went through in our own ways some type of trauma, especially early on. And that trauma may have been caring for patients who were sicker from respiratory virus than I often have ever seen. I know, Peter, again, the work that you do is different than the work that I do. But like in the nursing home setting, just the sheer amount of how sick people came. And like we've had Daryl Owens on one of our podcasts very early on. We had a nursing home director who basically everybody else called in, like stopped working in the nursing home. So he was doing everything. Remember that podcast, Alex? And especially in like these nursing facilities where you get to know patients over time, and then they were just devastated in 2020. I do have to say, still being in a nursing facility, it does actually feel like I have seen people get, and again, this is like these N of one. But like, I am just not as worried when my patients are getting COVID now as I was in 2020. And I think a lot of that is maybe my belief that, immunity works, that this is not a novel virus. Our body is adapting and kind of getting used to this and seeing it over and again. Maybe part of that is just denial based on, our own forms of trauma that we've all
COVID
experienced.
fatigue, trying to get beyond it.
Yeah.
And we should mention treatment. The treatments have improved dramatically since the beginning of the pandemic.
And we got vaccines. So how about we talk about that? So we have vaccines. I was super excited. I posted my Twitter pictures of me getting my vaccines. Number 1 shot, number 2 shot, number 3 shot. This year, I have not yet got my COVID vaccine.
What?
Yes. Well,
I got the double 2 weeks ago. The flu shot and the COVID
I thought you
vaccine.
got double COVID, like Norvax.
Same arm.
Well, part of it is I didn't sign up for both, so they wouldn't give me both at the same time. And part of it is like, man, I kind of also like, I don't think it's harmful, but I'm 49. Okay, for my listeners, I'm 49 years old. I am not sure there's a lot of evidence that it's that beneficial. Like if you look at other guidelines outside of the US, like the UK, they actually don't recommend a healthy 49-year-old to get the COVID vaccine. So where are we right now with COVID? Lona, should I call it boost? Like what's the appropriate term? COVID boosters, yearly COVID shots? Like what's the terminology? Since I asked you that same question about terminology in March of 2020.
I call them boosters, right? They are
COVID boosters.
But, I think we can vary. I don't know what Peter calls.
Well, I think the CDC wants us to call it COVID shots, yearly shots. But you're right, Lona. I mean, I think colloquially, everyone calls it a booster because most people have gotten tons of shots before. So, and the word booster suggests what it's supposed to do, which is to remind the immune system that what the virus looks like. So for some people, they need more reminders. Other people probably don't need or it isn't as urgent that they get that reminder. So that's kind of where we are.
And then what vaccines do we have right now? We have 3 FDA approved vaccines. Is that right?
Yeah, so we have 3 FDA approved vaccines. 2 are similar, the mRNA, Pfizer and Moderna, based on KP.2, one of the fluid variants, descendants of JN1, all Omicron. And Novavax, a traditional protein subunit vaccine based on JN1. Because it's more traditional, they had to decide the formula a few months before Pfizer and Moderna did.
So they're targeting similar but different strains?
They're all targeting the same similar thing. JN1 was what emerged last winter.
Yeah.
And JN1 then spewed a bunch of children out, including these hyper-transmissible variants over the summer with the prefix of KP, not Kaiser Permanente. And because mRNA vaccines are more nimbly manufactured, they can say, hey, let's just make a vaccine based on what's currently circulating, because the thing in the winter coming up might be more closely derived from that. But turns out that JN1 and its family are all very similar. So if you get Novavax or if you get Pfizer, Moderna, you would probably get the same benefit.
All right. If I was talking to my dad trying to convince him to get a COVID booster, should I convince him to get Novavax? Should I focus on KP2 with mRNAs? Does it not matter at all?
It probably doesn't matter, although I must say that Novavax does have a fan club. They have the fans of Novavax have a Facebook page. They advocated for it to come out earlier. So there's a big sort of cachet around Novavax. And the reason why is because it's more traditional. There were no head-to-head studies, but in the Novavax studies, they tend to have fewer side effects, just mildly fewer, again, not compared to each other. And, I think there's a lot of still people talking about mRNA vaccines, although personally, if you come back to your question on what you'd recommend to your dad, I would say either is fine. But one of my older relatives had just a really severe reaction to an mRNA shot early on, and he got myocarditis, which was very, very rare in an older person. He's in his 80s.
Yeah.
Then he talked to me. I said, try the Novavax, and he tried it, and not that it's again an N of one.
Yeah.
But he's continuing to get Novavax and updates.
Do both of them make you feel like not so great the day after, or like, is there any difference, or is it the more we use it, that post-COVID mRNA shot, like you don't feel great for a day?
I think that because they're so spaced out now, a lot of the side effects that we're seeing, like in adolescent males with myocarditis, happen after the second shot.
Yeah.
Because people are getting them further apart. It's not less of that 1-2 punch. So that's my hypothesis around that. But yeah, you aren't hearing people talk about sort of serious side effects anymore. People are talking about, some people are, oh, it wiped me out. Oh, I get on Friday because I want to make sure that over the weekend I can sleep on Saturday.
Yeah. Lona, thoughts from your perspective? Do you have any preference when you're thinking about it? Let's say for nursing home patients, older adults?
I think we use Moderna much more than Novavax and leave it on the patients for their preference. Some patients do have some strong feelings against the mRNA vaccines, in which case I think the protein-based vaccines come in really, really handy. But overall, we largely use mRNA vaccine. I have used Moderna for all of mine. And in my family, I do okay with the vaccine, which means that I probably am not mounting enough response. My husband is that kind of a person. He'll take it on a Friday and he'll say, okay, I can sleep it up on the weekend. So within the same, we all differ in how we respond to these vaccines. But overall, they have been pretty mild.
I just wanted to interject that there was a really interesting study at UCSF, actually, where by Eric Prather and Lisa Appel and others, showing that the more side effects you had, the more robust the immune response was. But also, if you didn't have side effects, you still had a good response.
So let me ask you a question, because back in December, years ago, when the new vaccine came out, I was super excited looking at the New England Journal studies. Clearly effective in decreasing bad stuff from COVID in people who have never seen this novel virus before. We're now 3 years later. We've probably all had some natural immunity. Most of us have had vaccines, 1, 2, 3 doses. What do we know about the evidence right now that yearly boosters in a population that's no longer, like, this is no longer a novel virus, but in a population that we're seeing it? I probably saw it this summer and didn't even know that my body saw it, just got rid of it. So what do we know about the evidence?
I mean, I think we should probably have better RCTs, as you mentioned, but I feel that a yearly shot definitely is going to be useful and going to be beneficial to patients and all of us, the general public, to reduce the circulation of new variants. So I do think that the virus evolves significantly enough for us to get our COVID shots or COVID boosters or, whatever we want to call it, at least once a year. I went through this doubt sometime in spring last year about the 6-monthly thing that's going to happen. And I was like, I don't see much in the community right now. Do I really, really want it? And the only reason I took it is that I really don't want to spend a day in bed. I just cannot afford that anymore. And that was probably the only reason I took it. So I think I can understand public being skeptical about it, especially about the 6-monthly sort of shots that we probably will end up taking, or at least that would be the sort of the soft recommendation coming out.
So Q6 months, twice a year.
I mean, I think about the shot as, and I love the way that Lona put it too. Of course, serious disease, hospitalization, and death. I think, particularly in our older populations, there is some evidence that, at least by antibodies, again, we're not looking at T cells with cellular immunity, it declines the fastest within 6 months. And that's why that 6-month thing came on board. But to tell you the truth, the people I saw in the hospital, and it's, it's corroborated by data too. I would say pretty much 100% of the people I saw didn't get a shot in the last year, even though they've gotten like 1 million shots in the beginning of the pandemic, and they were all older than 75.
Yeah.
So that's another thing that I would think about. And I worry about the every 6 months, it has to be messaged appropriately, because don't forget the lowest hanging fruit, the eyes on the prize is really for the older patients to get it at least once a year. And if you wanted to get the second time after 6 months, that'll be great, like during for the summer or something like that.
Well, it's really interesting because this idea of low hanging fruit. So if you look at the UK, they do not recommend it for non-older adults or non-immunocompromised. They are not paying for yearly boosters for like a healthy 49-year-old. So you would imagine, they just, they're probably using a lot less of it. If you look at nursing home, currently, it looks like about half of their nursing home population have had a COVID booster this year.
So they recommend them for all and will pay for them.
But just in a narrow population. We're going to just look at this low-hanging fruit, target all of our messaging, low-hanging fruit. U.S., everyone over the age of 6 gets a COVID booster. You want more than one? We'll give you more than one. Where are we with nursing home population? The group that probably is most at risk, I think it's less than 20%. At the same time,
less than 20% are getting the annual boosters.
Have gotten this year's annual booster. If you look at last year, same thing between the two group. Significantly less people in the U.S. in nursing homes got COVID boosters than the UK. And I wonder, part of that is we're different, but part of that is things are finite. We have finite resources. How much should we just target the people who are actually going to benefit from this? Versus constant messaging that everybody should be getting these COVID boosters, which also feels like, well, do we really have the evidence for that? Thoughts? You can call me stupid for thinking about this, but I worry because I do think I would recommend it for every nursing home patient, people who are immunocompromised. Even if we don't have randomized controlled trial, the harm is so small. And I'm fine with the antibody evidence. Peter, am I stupid? Yes, he says.
No, you're not stupid at all. You're not stupid because the UK is not stupid. So I think there is some truth in what a lot of truth in what you're saying. The way I think about it is, and it's really tough, this messaging. So first of all, historically, the flu vaccine was a targeted population vaccine, so very young and very old. And there is some evidence saying that when you make a vaccine universal, that you can get more people in again, I'm just quoting one study, more people who are actually need it to get it because there's less confusion.
Yeah.
And more people are more vulnerable to have access to it. So somebody who is not in the system. But with that said, the way I say it is that everybody is allowed to get it, but I really want the people who are 65 and definitely over 75 to get this vaccine because they comprise over 90% of the population who are hospitalized with COVID in the United States and, from 2023 onwards. Yeah. So I think that's the way I put it. And of course, there are other benefits too that decrease long COVID observational studies by 70%, has a benefit of reducing infection if it matches the circulating variants. Like if you get it now, you can kind of get 6 to 8 weeks maybe of lower risk for holiday parties and things like that. So, there are other benefits as well.
Yeah. So a lot of observational studies saying that it benefits. I want to highlight one thing you said too is like flu shots, feel very different also because it's a different virus. But part of the reason that we're advocating for twice a year, sometimes even more, like the most recent guidelines, you can get more than 2 shots a year for specific groups, is that immunity, or I want to say immunity, right? We had Monica Gandhi on. She taught me the importance of there's more than antibodies. You got T cells out there. But antibodies kind of drop after 2 months? From an antibody response, we start seeing that wane. So when is the right timing that we should be giving these vaccines to our nursing home populations? Because we're kind of in a lull. We're going to start seeing it come back in November because it always does. It's going to peak in December, early January, and then it's going to have that same cycle with the next late spring, summer peak. Lona, do I wait? Do I perfectly time it? Do I just jump on the bandwagon in September and give it?
I think September, October is a good timing to give, just because that's the time when families start making plans, start getting together in November and December, and you want the immunity to be there. So I feel the fall timing is reasonably good. The main question is the next timing at the 6 months. If we do decide to go that route, what is the good one? And I think we'll need to see a couple of years of more pattern. I was looking at the curves from this past year, and, the spike was in June. CDC now collects data from nursing homes on COVID-19 in nursing homes. There was a spike in June. And I'm certain that this is related to the community transmission around that time as well, which brings us to a couple of different points regarding your original question. One is that among the immunocompromised, among the elderly, we should definitely consider vaccine. Among us, healthcare providers who care for the elderly, I think that is a good thing to protect ourselves and our patients. And there is a herd immunity that comes with that. And probably is a tipping point that if enough people get the vaccine, then the downstream big outbreaks that we see probably will not be seen.
So you feel like it actually impacts transmission?
Yeah, I do feel that it does impact transmission to some extent. But I don't know, Peter, what do you feel about it?
I agree with you, Lona, because even if you just think about symptomatic infection, sure, the studies in households have not proven that it reduces transmission the same way that, say, a flu vaccine or a Tamiflu. But, if you reduce the person who's getting the vaccine from getting symptomatic infection, if it's matching the variant circulating, and you just got the vaccine, then you don't have it to then transmit it to a vulnerable patient that you're taking care of.
Okay, I got one more question about vaccine because I want to go on to treatments too. Is that, do you think we can do a randomized controlled trial of these vaccines, given what we know right now, to convince hesitant individuals that, hey, this does it? Because if you look at the observational studies, the effect size is quite large in these studies. So it shouldn't take a monstrous trial if I'm truly to believe the observational studies.
So you're assuming that the reason that rates are so low among older boosters and among nursing home residents is because of lack of information, that we need a randomized trial.
Well, you got one person on this Zoom call, I'm not going to call him out, who has not yet had the COVID vaccine. And I do think that if I saw really good evidence that yearly vaccines in immunocompetent individuals who've seen COVID before, who've got shots before, like for me, I do think so, because it kind of, the alternative is like we're just spending a lot of money on this thing that other countries are not recommending. And that's the other thing, is that you're seeing diversity. Most countries actually do not follow CDC guidelines. So the question is, can we do a randomized controlled trial in the US?
Of the vaccines?
Yeah.
I'm not sure it is going to be ethical anymore to do an RCT of a vaccine that has shown to be...
Why not? Most people don't even take it.
Sure, there are other designs that can be done. I'm not sure it is possible. Now, in nursing homes for flu, as you know, there are many sort of cluster randomized trials that are done for, trivalent, the different kinds of flu vaccines. That's probably possible.
Yeah.
Not sure if a randomized control trial would be approved from ethical bodies. They would certainly be very strong, but we would probably have to rely on other types of designs, study designs to be work.
Peter, do you think?
I don't think you're going to get buy-in for a randomized control trial for the reasons Lona mentioned, but also because it's going to be so expensive. And I can imagine pharma or vaccine companies jumping on that bandwagon.
Oh, they're not gonna, because we're already giving it, right? Like there's no economic reason to do a randomized control trial from a pharma company. You can only lose.
There are trials. Well, they are small studies so far, but you could, I love the idea of looking at the flu models in nursing homes, for example, quadrivalent, or I mean the high dose flu vaccine, or the adjuvant flu vaccine. So there are new formulations coming out with the COVID shot, like a flu and COVID together. So you can look at those kinds of things within populations.
And I wonder, since we have one vaccine targeting JN1, another targeting this KP2, I wonder if there's any information to be gleaned by the difference in those two too.
I think that JN1 and JN2, correct, Peter? If I'm
Or JN1 and KP2.
Yeah.
KP2 is the child of JN1.
Yeah. Well, I want to go to treatments because this brings up the other question about Paxlovid.
Wait, before we go to treatments, just thinking of I want to move on from Eric, 49-year-old person, and get back to our Jerry Powell audience. Older adults, people with serious illness. Can we talk briefly about people with serious illness? Is there a lag time to benefit for these vaccines? So, for example, we have a hospice unit in our nursing home, and those patients typically have days to weeks, maybe months left to live. Should they be getting the vaccine? Or do the harms, the short-term harms, potential harms, outweigh the risks for people with limited life expectancy?
Well, I can start about. Really love to hear Lona's take on this too. Well, I think the vaccine, there are very few harms right now, to tell you the truth, particularly if somebody has had the vaccine successfully before. And we know the longest it takes to get up to that top peak antibody is maybe 2 weeks, but probably in a few days if you've been experienced before.
Yeah.
And it also helps against MI, stroke, but those are more long-term things. Yeah. But I think getting seriously ill can happen pretty soon after COVID. So I would say, as an ID doc, that I would offer vaccines to those individuals because I want them to preserve their quality of life, in the period that they have.
Yeah.
Lona?
Yeah, I don't think I would necessarily withhold vaccines, from patients, older adults who are in hospice. Ultimately, it comes down to what does a quality of life mean? Some people feel that they are doing fine right now and do not want to get COVID because in 2 months they have their great-grandchild's, graduation, and they don't want to risk anything in between. Just as an example, so I may not be the person who makes a policy that they have to be or they have to reach a 70% target or those kinds of things, but I would not withhold it.
I think in practice, a lot of us don't do it for people who have less than 2 weeks to live. Because if anything, because I agree, I think the safety of these drugs is great, but the possibility of feeling crappy for a day just getting the shot, I do think we have to think about for our hospice patients.
So maybe less than 2 weeks, maybe don't recommend it. More than 2 weeks.
We'll see if Peter thinks I'm stupid for that too.
No, I like the 2 week thing because from a scientific point of view, 2 weeks is also the time it takes you to get to that level.
Yeah.
Yeah.
That's helpful. Okay. Thank you.
Treatment. Alex, can I go to treatments?
Yes. For older adults or people with serious illness. Not Eric Wadera.
Older adults.
I'm giving my co-host some grief.
Not a 49-year-old.
I never know how to pronounce this one. Molnupiravir. I never use it. I've never used it. I've never seen it used. How do you pronounce it? Peter?
Molnupiravir.
Is it something that we should still use if we've never used it?
There is still a place in the world for it, and I'll tell you how I think about it. So, of course, everybody's heard about Paxlovid. We'll talk about that.
Yeah.
I think if you have access to an infusion center and you can't take Paxlovid because of the 120 potential drugs that people might be fearful of for drug interactions, then remdesivir in infusion center is my next go-to for 3 days. If you can't get either of those two and somebody didn't get vaccinated or you're worried about them, a 30% benefit with Molnupiravir might be worth it to some people. So it's well tolerated, but you get a 30% back.
I thought wasn't panoramic negative? Was that another study? Was that the UK panoramic study? They had like Paxlovid and Molnupiravir, whatever. Was that a negative study? Was that a positive study? Do you know much about panoramic?
I can't remember the details about that study, to tell you the truth, except that Yeah, it didn't show quite as much benefit as people thought. That's the punchline I remember.
Yeah, that's because it was Lancet last year. I think this goes to Paxlovid, is that, and potentially my concern, like with the vaccines too, is that the early on studies were pre-Omicron, most of us ever seeing this virus before. And you look at like Paxlovid, Epic HR, the first one, high risk patients. Most of us have never been everybody not vaccinated. Great drug, right? I would say it had a pretty good effect size. It looked like it really worked. Published within a couple months of completion, showing in New England Journal, showing it works. Epic SR, standard risk patients who've standard risk not vaccinated or high risk with vaccination, really no statistical difference between the two groups.
Well, I think it comes back to what you've been saying before from the beginning we started, which is that I think the answer is yes and yes, because when you look at, Panoramic or Epic SR, you're mixing people, both unvaccinated, vaccinated, younger, older, etc. Well, SR was mainly, a younger group versus the pure original studies. So the answer is, for the right patient, it's still really worthwhile.
Who would be the right patient in your mind for Paxlovid?
Well, the people who I saw in the hospital who may not have been there if they got Paxlovid, because none of them got Paxlovid either.
So older adults, high risk, immunocompromised, older adults, certainly nursing home patients. Is that right? Lona, would you agree?
Correct. I agree. And there is, although not RCTs, there are observational studies that, the symptoms and the long-term symptoms of COVID are fewer with Paxlovid. So I would say I can understand the public skepticism because of the newer studies and conflicting data. But I would say older adults, immunocompromised, high risk of hospitalization, should probably get Paxlovid.
Yeah. And then again, I feel like this is another one, like, man, it would be great to have more data, like more, high grade data, high quality data, randomized controlled trials, but we're just never going to get it because there's no incentive. And I guess
you mean incentive to the pharmaceutical
industry. Well, I guess Panoramic, we're still waiting for Panoramic Paxlovid study to come out. Yeah, no bet. Yeah, pharmaceutical companies are not going to make money on this. They can only lose. I mean, Pfizer.
Yeah, so the way to summarize, the way I think about Paxlovid is really the shoulds and the coulds. And again, it's just like, your discussion about vaccines. There are people who need it much more.
Yeah.
But that's getting lost in the average message. And that's my concern.
Yeah, I think that's my concern too. I guess one other question is, like, nursing homes are a weird population. It's not really inpatient. And in inpatient, we use a lot of remdesivir. Do we still use a lot of remdesivir? Is that, like, Peter, if you're admitting somebody?
100%. Because you don't know where they're going.
Yeah.
And remember when President Trump had COVID, everyone's waiting for day 7 because you kind of have mild symptoms in the beginning. And I think that's another myth. My patient has mild symptoms, 85 years old, didn't get the last booster. Yeah. But look, it's really mild. But remember, you don't fall off the cliff until day 7. So you can't really use that as and when people first come to the hospital, you don't know where they're going.
Okay. Now, nursing homes, not really truly like community-based outpatient, not really inpatient. Like, I think our nursing home still has a preference for remdesivir when the patients get sick, which always confused me. Like, why aren't we using Paxlovid? Because they are still technically outpatient. Lona, like, what should nursing homes be doing around?
I think the short stay populations are probably a little bit, different than our long stay populations. But I have largely heard Paxlovid being used more than remdesivir in nursing homes.
Okay. Same thing with you, Peter?
People use Paxlovid more, but they are also worried sometimes about drug interactions. I would say many of these worries are sometimes unfounded. And I think working with a good pharmacist will help reassure you that, it's going to be okay. And I oftentimes advise people to have a Paxlovid plan So you kind of know what's going to happen in case somebody needs Paxlovid, but much easier to give than remdesivir.
All right, I got one last question. Alex, do you have any questions before I ask my question?
No, last question, yeah.
Magic wand. You had a magic wand right now. We are in year 4? Year 4 of COVID. What are you hoping in 2025? Lona, 2025, you got a magic wand. It has to be used in some regard regarding COVID. What would it be?
I'm hoping with the magic wand that the virus gets even weaker and we have fewer spikes. Summer spikes and spikes.
Do you think that's going to happen? Like, it's a coronavirus, right? Like, it's just going to constantly be around with us. I guess it's a magic wand, so it doesn't even matter. If
Maybe the host gets stronger. Maybe the totality of the humanity is stronger in beating the virus. How is that?
I love it. Peter?
I'm going to be more existential about my magic wand, which is, well, it's not really existential, but my hope is that we have much more trust in science and medicine and less divisiveness and less misinformation about vaccines, because it's bleeding over into lots of other vaccines for kids, measles, etc. So that's really my hope for 2025.
Alex, you got a hope?
I hope I can catch my breath at the end of this podcast.
Oh, no, that's my line. Well, I will say, actually, I got a hope. I actually do hope that in 2025, we'll get some more kind of randomized control trial out there, because I do think that the antidote to misinformation is actually evidence. So that would be my hope. Alex, take my breath away. Wait, this is not Take My Breath. What's the title of the song?
That's Top Gun.
That's Top Gun.
That predates this
Top
song
Gun,
by a little while.
Catch my breath.
Serenade me as I drive my motorcycle with you in the back, Alex.
It is correct.
Catching my breath, letting it go, turning my cheek for the sake of the show. Now that you know this is my life, I won't be told what's supposed to be right. Catch my breath, no one to hold me back, I ain't got time for that. Catch my breath, won't let it get me down, it's all so simple now.
Peter, Lona, thank you for joining us on this podcast.
It was so fun. Thanks. Hopefully I can get Lona to paint me a watercolor of a COVID virus.
Okay, I can send you a print. You might like it.
Please do.
And to all of our listeners, thank you very much. Don't forget, if you're caring for nursing home patients, give them that booster this year, no matter what you do for yourself. And thanks, everybody. We'd also like to say a very big thank you to the donors who've donated more than $250 in the last year to support the Jerry Pal podcast, including
Asher Edwards, Jerry Gerwitz, Victoria Brond, Meg Walhagen and William Strawbridge, Jessica McFarland, James Tulsky, Susan Nelson, Sharon Brangman, Daryl Lowens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, and Stuart Oserman.
Thank you very much.